Our second presentation today is entitled Promoting Personhood and Perspective, Pediatric Neuropalliative Medicine and the Importance of Prognostic Awareness. Our presenter is Dr. Lauren Treat. Dr. Treat is a neurologist and palliative care medicine physician at the University of Colorado Anschutz Medical Campus and the Children's Hospital, Colorado. Please refer to the conference website to see and read her complete bio. Also, please reference your screen for the CEU learning objectives and accreditation and disclosure statements, as well as viewing the information on the continuing education tab in the attendee website. Dr. Treat has no disclosures today. So now, without further ado, Dr. Treat, the floor is yours. Thank you.
Thanks so much, Dr. Thomas. I'm really glad to be here today. I'm going to share my screen so you can see my slides. Okay, and here we go. I love what I do, getting to combine neurology and palliative medicine, and I'm hopeful that over the course of our short session here today, that you'll get a little bit of a glimpse into how these fields naturally combine themselves and what you might take away for your own practice from the niche that I've created. We are here in this Mountain States Regional Network Summit, and speaking of mountains, as I list my no disclosure slide here, I'm going to use a lot of metaphors throughout this talk to help illustrate points. And so we'll start with this first iconic image that many of you will recognize, this nature scene of Maroon Bells, which is near Aspen, and it's photographed here in the summer. I think this is a really fitting image to start this talk because I'll use the image of people on a journey or on a trek through their serious illness experience. And we often recognize that families have a long journey ahead of them when we meet them. And sometimes it's more than the family might seem prepared to be going on. But whether we meet them down in a meadow where there's flowers around or up on a rocky ledge, there is a sense of things to come as they continue to travel with their loved one, with their families. And we, as clinicians, often serve as guides on that journey, helping them be aware of rough patches, as well as where the scenic views might come, and suggesting, that turning right or turning left at various different forks in the road have different opportunities and challenges to them. So the learning objectives today is to talk about genetic diseases and the narrative that surrounds them. Many of our genetic diseases involve an element of health fragility and often require families to make medical decisions at various different time points. And so the broad category for these kinds of circumstances can be described as a serious illness. And so there's some common themes that families and medical teams encounter when caring for an individual with a serious illness and a genetic disease. And so I hope to clarify some of the terms, especially about palliative medicine, because there can be a lot of misunderstanding. Make sure we're using all the same language there. And then we'll look specifically at neurogenetic diseases and the narrative embedded in some of those trajectories to call out some of the unique impacts that these conditions have on personhood and on parent narratives. And I'll advocate for specific attention to the paradigm of how we talk to these families and what communication tools I believe need to be developed in order to keep pace with our technological advances and not leave families feeling abandoned on stretches of their journey. Along the way, we'll highlight some specific tools for practice that you might consider incorporating into your own visits. And I'll try to be really explicit about those when we're talking as well. So just a quick slide to clarify some misconceptions up front. Hopefully you've heard this message clearly before, but just to reemphasize from the beginning that palliative medicine is not synonymous with hospice. The hospice portion of palliative medicine refers narrowly to support at end of life, whereas palliative medicine takes a much broader view of how to support people at any point in their serious illness journey, including from the time of diagnosis. We'll keep talking about this just a little bit here, but recognizing that a lot of stigma and misconception exists both within the community with our families and also within medicine with other physicians and care partners. So here's the positive framing, what it is rather than what it's not. Palliative medicine is a medical specialty that helps people with serious illness live as well as possible for as long as possible. And I really like this image of being sheltered from the elements, this bright red umbrella, seeing medical challenges as some stormy weather and equipping the patient and their family with the appropriate protections, including a cloak and an umbrella. And if we think about palliative medicine as that broad umbrella, we can talk about the things that come under that umbrella that palliative care seeks to provide and support. One of the big tenets of palliative medicine is an acknowledgement of suffering in all domains, not just the physical domain. So talking about emotional and psychological and even spiritual distress and suffering, and taking that holistic view of the individual in the context in which they live, including the caregiver and their community. And really a big emphasis under that umbrella as well is supporting medical decision-making in the context of all of those different elements, trying to understand then what does it mean for this person to live well and to have agency and choice in how they accept their medical care and the different kinds of supports that are available to them. I think a lot of people assume that palliative medicine is about dying, but once you've realized, or once you've experienced what I call the alchemy of palliative medicine, you realize that it's really actually about living life well. And that's generally in the face of challenges that make it hard to live the way that you want to. And so we'll talk about that a bit more today. Just one more slide to kind of address this stigma, where that stigma come from. That palliative versus curative dichotomy continues to exist in medicine fairly prevalently, whether it's in surgery, talking about curative versus a palliative approach, or even in therapies that we're talking about. This therapy is only palliative versus curative. And so I think it can become very confusing for clinicians and for families when these terms are used without consistent meaning. And this is a flaw overall in the way that we speak about this subspecialty, as well as the way that it shows up in other areas in medicine. And so I'm working hard, and I'm trying to help colleagues work hard to clarify this in their minds and also understand the way that it comes across to families. So importantly, palliative medicine originated within the field of adult oncology. And so that top graphic that you see there, it's a lot more of that old model where things are a lot more definitive in terms of whether people are on treatment, focused on cure, versus palliative, which usually means not aimed at cure. And so in that old model, the vertical line represents that point at which you do a complete 180 and you trade teams for one another. And there's a lot of angst about when we do this and how we do this, and are we abandoning, and have we done too much, and have we done too little? And so we've tried to move away from that old model towards the better concept that you see at the bottom. And this illustrates the relationship where palliative medicine is able to be introduced early in the course of the journey and allow for a longitudinal relationship, whether that happens right at the time of diagnosis or some other time early on in the trajectory, allowing that relationship to grow over time and be responsive to needs that arise, and really try to reduce that distress about, is it too early or too late? We're not trying to exchange one team for the other. We're trying to have both teams involved, the disease modifying or potentially curative teams and the supportive teams, and not making families feel like they have to choose between those either. Families want the best possible chance they can get aimed at hopefully modifying or curing the disease. And they also want support and comfort-focused approaches. And they want to be able to talk about those in a dynamic fashion as well. And so this is not generally a straight line as represented here, but it's more an idea that both can coexist and ideally ebb and flow in response to what's happening with the patient's condition and the family needs. In this newer concept model, there's much less focus on the wrong time to introduce palliative medicine. And there's no sense of failure if palliative medicine gets involved and a patient lives for years or even decades after the introduction of services. That's actually a success that gets them a higher degree of support for a longer amount of time, and everyone wins in that scenario. I think this new model also allows us to explicitly acknowledge that a grieving process starts at the time of diagnosis and requires specialized support to help cope with all of those events and the medical decisions that are impacted by that grief, that loss of normal, the loss of the hopes and dreams as someone thought they might be, this impacts the narrative about the things that a family chooses in the future and the things that they give up along the way. And I think this is especially important to recognize for parents supporting a child who has a serious illness. Children represent so much potential and hope, and that grief over lost expectations or plans is a really significant part of palliative medicine for children. Let's talk a little bit about palliative medicine broadly in the adult side and then on the pediatric side. So again, when palliative medicine originated in the adult world and mostly in oncology, we were able to talk with the person themselves about what they value and what they accept for their own life. And if we're not able to talk with the person themselves, then we can talk with the people who knew that person well, and they can tell us about what that person expressed or the choices that they made about what they found meaningful or tolerable in their life. With children, we don't have the luxury often of talking to the individual with a fully developed brain that was cognitive and able to reason through things and have delayed gratification. And that's especially true in neurological diseases. And so we ask their parents and guardians to make decisions on their behalf. And this is clearly different than asking the person themselves. It's a different thing to make a decision on behalf of another, whether they're your child or a loved one in a different way, and especially hard to make a decision on behalf of someone who's never been able to articulate something to you. So whether that's because they're an infant and they don't have those developmental skills yet, or because the disease itself impacts their ability to rationalize and speak and communicate in those ways. And so we have to consider what hopes and goals the family has and what parents hold as their own duty to protect and provide for their child. In ethics, we refer to this as the best interest standard, and we allow parents to have a strong voice in defining what that is, what's in the best interest of their child based on the context of that family. In both adult and pediatric medicine, the purpose of palliative care is, as a medical specialty, is to make sure that patients receive goal concordant medical care. So this is a big misconception as well. Sometimes people feel like palliative medicine is there to try to talk people into a comfort-focused approach or talk them out of aggressive medical interventions, and that's not true. Palliative medicine is there to clarify the family's goals and values, what it means for them to live well, and then to apply that knowledge to the medical treatments that are at hand and make sure that they understand that their goals will be best reached with this or that support. And also acknowledging that sometimes their goals and values are in tension with one another. They want to have the longevity factor, but they also want to have that comfort focus. And sometimes those two can't coexist as much as we wish they could. Palliative medicine is about helping families understand that choosing a particular treatment or path forward will get them either closer to or farther away from the things that they've told us are central to living a meaningful life with the people they care about. Another big difference is that the utilizers in the different subgroups. So in adult palliative medicine, there's still a really, really big focus on oncology, and that's a majority of people served by adult palliative medicine. And underneath that come the neurological diagnoses, some things like Parkinson's disease, dementia, those sorts of things. In pediatric palliative medicine, it's actually the opposite. Most of our children served by palliative medicine in the pediatric context have some sort of neurologic complication. Often that is a genetic or metabolic condition, whether it's diagnosed or presumed. We all recognize that there's a lot of things that we don't have a name for, but we suspect have genetic origin. And then the oncology population is really only about 20% of the people served by palliative medicine on the pediatric side. One of the other major differences that's really important to point out in just the populations that are served in palliative medicine is the amount of support that's available to them in the community. While adult patients with complicated bodies can often go to a skilled nursing facility or a long-term acute care center to receive their care, we have to acknowledge that there aren't any skilled nursing facilities or LTACs that will accept children in the state of Colorado and in many of our surrounding states. Sometimes there's some rare exceptions, but because of this, all of the caregiving burden falls on family members by and large. Sometimes the children live in the hospital, but we have to recognize that that burden of care falls very squarely on parents in addition to that decision-making burden. And so, we thankfully in Colorado have some benefits from our state as far as paid caregiving, but still trying to recruit nursing and staff to a fully sufficient model has been very, very challenging, especially since COVID with nursing shortages and these sorts of things. So again, just setting the stage for the population, the type of considerations, and how we can go about supporting them. So let's focus specifically on neurological disease, neurogenetic diseases as a special kind of serious illness. What's specific about that narrative? In my opinion, neurological impairment has really big implications for living life, both in adults and in children. There's high rates of disability. Our families are often very used to caring for their children when they're very young. An infant needs to be fed, an infant needs to be carried, but these children grow into bigger bodies, and that disability becomes more of a challenge with the child growing into a bigger body. Disability often translates into consequences for other organ systems, like we've discussed already, that sometimes the fragility, that fragile factor, is something that families have to contend with. And there's really important human elements of neurological dysfunction that impact personhood. If you ask an adult what they think characterizes their own self-identity, a lot of it is rooted in our neurological abilities, our ability to reason and speak and learn, have agency, make choices. And so people struggle in a profound way with reconciling the loss or absence of those neurological abilities with their meaningfulness. Why am I here? Why am I on this earth? So how do I show up as myself in these circumstances? And so families also recognize this as they think about their children. Who is this person now? Who will they be in the future? How will other people interact with them? How will they express love? How will they be in relationship with people? Will they have skills or talents? And so our ability to talk to them on that level is really, really important. I think that disability and the sequelae of neurologic disability, whether it's the motor or sensory or cognitive disability, that often lends an increased sense of medical fragility to them, an inability to take deep breaths on their own, inability to move their body to protect it from harm. There's this sense of increased frailty or fragility for them. And then there's also this other theme that comes from those other aspects there about complex grief and relationships. And in pediatrics, we have to recognize that there may be years or even decades of life that are going to happen with this child, and we have to set families up for a long journey and help them understand the degree of time that this is going to involve. With the advent of more and more life-sustaining medical technology and an increased ability to rescue people from serious complications related to their underlying condition, we have to recognize that we draw things out a lot in medicine. And there's a really poignant quote that can sometimes feel a little shocking that a colleague a few decades ago is quoted to have said, but this quote says that death no longer comes swiftly and mercifully for adults and also for children. And so we are glad that we've been able to help children live longer. We're glad that we've been able to put technology in place that allows them to have meaningful lives for longer periods of time. But we also have to recognize that we've created the potential for long and complicated roads, sometimes involving different degrees of suffering over time, but especially when that trajectory starts in the first hours, days, or years of life, we have to just acknowledge the dynamic that we're creating and adding to. And I think many of us will agree that in the superhighway of medicine, we don't have many signs for off-ramps that potentially could be even just discussed or acknowledged with the family. And so we have to be pretty aware of those dynamics. So pediatric palliative medicine or pediatric neuropalliative medicine is about helping children with serious neurological conditions live as well as possible for as long as possible, like you saw in that early slide, and requires acknowledgement of these specific dynamics. I think my perspective is that considering being asked to be in the decision maker seat for these families is tremendously strenuous as far as psychologically and emotionally intense. And so we have to understand that burden on parents and also help offload a little bit of that burden by rooting their decision in what the child's body is telling us about their ability to live well or not, rather than just asking parents if they want this, yes or no. And so we can help parents over time orient to the true tragedy of failing bodies, genes that didn't develop the right way, rather than failing love or failing care, because we always say that their love, is so strong, and if that was all that it took to correct this or save their child, they would live forever. So how do we accomplish this work? My perspective is that we have to bring in specific tools for the job here. Some of the big themes in this section are methods to manage the uncertainty. People are definitely trying to figure out how to reduce the uncertainty, how to know more, how to have better prognostication. But in the meantime, we have to think about avoiding letting uncertainty be a barrier to dealing with what we do know, what we know about how someone lives now, and what we think about the near future and how that might look for them. We also have to acknowledge chronic fragility, this unique theme, this unique dynamic where repeated rescues come up again and again, and understanding how that impacts on a family's psychology. We also need to ask specifically about personhood. We do a lot of attending to the physical body, but we need to understand, who is this person? What do they show us about what they enjoy? And how do we help them have good days, or what gets in the way of them not having good days? And supporting families with spiritual care and social work and bereavement to process their complex emotional experience. And then on top of that, we have all of this caregiver exhaustion that's so prevalent. And so we have to understand, both on a human level, how we talk about it and acknowledge it, and how we advocate for systems change. If we're going to help children live longer and longer in our society, we also need to be advocating for resources to support them to an appropriate degree. So this is one of the big tools that I'm going to talk about in this lecture today, and I think hopefully you'll find it helpful. I call this characterizing the mindset, or characterizing the psychology of the family that's coming to see you. So bear with me here as we talk through these different phases of how families sometimes show up in our practices. I think it's very helpful to characterize, either in the clinical encounter in real time or in preparation for an encounter, where the family is at psychologically with regard to what they're focusing on, where their lens is in terms of how they're viewing the medical care. This graphic illustrates the evolution, maybe potentially you could say a maturity process, because it does often go in one direction, that we've often seen in ourselves and in others who face serious medical illness, about the way that hope changes over the course of the illness and the way that the perspective changes. And so bring to mind someone who you've recently given a new diagnosis to, and you probably will see in that conversation some of these themes about the focus of their care being a lot on cure, or being able to beat this. Even if the odds are low, there's still a hope and still a sense of, what do we need to do? What do we need to do to try to move the needle on this and be thinking about beating the odds here? And so we see families in this initial phase invest so many resources in trying to do that, whether that's financial resources or just energy resources. They're willing to tolerate a lot of unpleasantness, a lot of things on their schedule, a lot of tests and procedures, perhaps, to try to get that chance to have that trade-off, going and seeing second opinions, going and getting all the expert input on this. They're willing to tolerate a lot of that stuff. And conversely, the emphasis on the quality of life in this phase is pretty low. They're pretty willing to invest in that chance, whatever it is, even if it's small, of trying to get a better outcome in this initial phase. Some families, not all families, move towards the right here into this chronic phase. And it's variable about what moves people between phases. Sometimes it's one event or one conversation with someone, and they see the diminishing chance, or the diminishingly small opportunity to actually impact on the outcome. Sometimes it's just sheer time. That initial phase is a very energetically intensive phase, And sometimes it's just not able to be sustained for longer. And so in the chronic phase, people are still very hopeful that they can change the outcome, that they can impact it, that they can prolong life, and they still want to fight against this thing that's going on. But you see a little bit of a shift that they're not able to sustain that high level of sacrifice, that the unpleasantness tolerance still relatively high, but there's this increasing emphasis on quality of life because they have to sustain, they have to understand, how this is going to go over a long period of time. And in the chronic phase, there's a lot of vigilance, a lot of trying to figure out where threats will come from. And so trying to understand how families are trying to stay vigilant for what's been coming up is a big piece of that chronic phase. Now, again, some families move from the chronic phase into a third phase, and I have a little bit of mixed emotions about what to call this phase. Some people call it a resilience phase or a peace phase, but in this third phase, the people who move that direction often are changing their perspective once again, that there's a shift towards centering their decisions on what's happening more in the short term. How do we kind of reclaim agency and reclaim our ability to understand what the child can meaningfully do today? What can our family meaningfully engage in today? Not always at the expense of tomorrow. Sometimes it's because that expense was too high, or sometimes they recognize that they didn't get to that goal that they were trying to invest in to get to. And so people move through these phases at different times. But I want to be sure to recognize that it's not right or wrong for them to move through the phase. I want to just comment here that this is just a pattern that we observe in how families move through this. And what I've come to appreciate is that time is an important factor here. Certainly the time factor could be the x-axis on all of this, but it's not the only ingredient here. The lived experience is part of that time factor, but what I think translates from that lived experience is actually something called prognostic awareness. And by what I mean by that is one's ability to recognize more fully what's happening right now with the child and what the future may look like for them. And prognostic awareness is developed through lived experience. Maybe it's even through a lived experience with another person with a serious illness, but it's not always developed at the same rate or even in the same circumstances. Someone might walk away from one circumstance with a different degree of prognostic awareness than a different person. And I spend a lot of time thinking about to what degree clinicians can shape prognostic awareness with their families and seeing this as a potentially modifiable factor that changes the way that families might approach the decision-making in a medical context. So just a couple of caveats about this. I think it's really important to not assign moral weighting to which stage someone is in. It's not right or wrong for them to move in these directions. And there's not a failure on the part of the clinicians if someone stays in that initial phase. Sometimes we feel like, you hear this a lot, they're not getting it or they don't understand. If someone stays in that initial phase, it's not more right or wrong for a family to be in the peace phase as compared to the initial phase. We understand that the third phase, that a lot of us hope for people to get there because there's greater prognostic awareness and greater sort of sense of peace and resilience associated with less anxiety and depression. And it often makes our clinical encounters, frankly, go more smoothly when a family has greater prognostic awareness. But this, again, is not right or wrong. It's not something that families necessarily even have insight about themselves with this, and the way that they focus on cure or hope in these different phases can be culturally informed as well. Some people from different backgrounds move through this at different rates. I want to point out that it can be challenging when one parent of a dyad moves through these stages at a different rate compared to their partner. That can set us up for some challenge with conversations and decision making. But I also want to emphasize that families in the third phase have just as much hope as those in the initial phase. Hope is present throughout this. They both hope daily for a cure. And I think that it's often misperceived that a family in the peace phase has given up some hope. And sometimes that might even be something they're accused of by other loved ones or family members, that they've given up hope. But they both, families in all of these phases, hope daily for a cure and for a good outcome. I think it's important that those in the third phase, they've added additional hopes to their list. Their hopes for quality of life are just as strong and sometimes even stronger than their hope for a cure. And so we have to understand that about the families in all of these phases. The other thing to point out is that unpleasantness, I use that word intentionally in this model because some people call out suffering in their own view that the family does not agree with. And so we can't judge the suffering of the child based only on our own perceptions. Yes, we are advocates for the child, but we also have to ask the family, what comprises suffering for this child? What do you view and how are you interpreting it, rather than using our own definitions? All right. So again here, how do we use this as an intervention? What is the role of the clinician in helping families in these stages? And I say very carefully here that clinicians have influence and responsibility here, but not control. So again, recognizing it's not your job to force people through these stages or to help, to make them transition from one to the other. And it's not necessarily a reflection of your care if a family stays in phase one, or a reflection of your communication skills. Again, there's many individual and cultural factors that influence their staying in one phase or another. But clinicians do have the opportunity to help families at least recognize the phase that they're in, and a responsibility to speak up about what they're seeing as an advocate for the child, as well as an expert in offering clinical insight. So calling out what you're seeing, something like, I see how hard you're working, or what devotion you have to helping this child improve her muscle strength. It seems like the goal that you're aiming for with all of these therapies is that she's able to do X or Y. Is that right? Asking for their buy-in with that. And they might say yes, or they might say, no, that's not quite it at all. But then you're able to say, okay, I understand that's a very reasonable goal to have. And I also have to layer in my expert opinion here, having seen other children with this condition. It's very unlikely that we get to it. So let's partner together to make a time-limited trial to see if we were going to see this outcome change. I think we would see it by time point X or Y. So let's work together to help identify some of these goals. And families might bristle a little bit about that, but if you engage them, rather than try to shut them down in their hope, but if you engage them instead in some sort of time-limited trial to say, let's see together, let's keep track of this together so that we can understand where to invest our energy or how to invest our energy. That can be very, very powerful. It helps reduce caregiver isolation. I think it helps families feel seen a little bit more. And it also emphasizes personhood. You can say things like, it sounds like she really enjoys the time that she's in therapy. Is that true? And if the family says, no, actually it's like really a struggle for this child for these reasons, then we have to say, gosh, that's important for us to keep track of too. If it's intrinsically valuable or enjoyable, maybe that's the thing that we focus on rather than this longer term goal. But if it's not intrinsically valuable, that's an even more important element to add to our equation here about whether we keep pushing on this specific thing. And so by calling out your perception, you offer the families this chance to be seen and recognized for their work and for their investment. And you also help characterize the trade-offs that they may be consciously or subconsciously making. And again, engage that partnership and offer your expertise in that partnership way. I'm going to add one more layer here as we're getting close to the end here about a good parent narrative that many families, we have data on this phenomenon, that many families of seriously ill children, including children with genetic diseases, tell us that they have an internal definition, a personal belief about what a good parent should do, how they would focus on things to fulfill that internal definition and how that affects their thoughts and actions. And so whether parents achieve that good parent belief for themselves really affects their sense of coping during an illness and also their bereavement outcomes if the child does pass away. It really affects their sense of whether or not they did an adequate job of showing up for their child in various different circumstances. And parents want to know very, very much that they were a good parent to their child, that they advocated for them, that they protected them, they supported them, that they cared for them well. And so this is a very prominent theme that can be helpful to talk about actually in the clinical encounter. And so just layering that in then to this model, we can add a line in here about the risks to whether someone feels like they're achieving that good parent narrative. And I believe that in that initial diagnosis phase, there is a high risk of failure. Things are outside of their control, and they feel like if they don't get someone to all the experts, or, invest and sacrifice to this high degree that they somehow have failed as a parent. And that's a really challenging place for that family to be. Over time, as we move towards that peace phase, to me, there's less risk of failing to be a good parent, because you focus on things that are more quickly under the control day to day of how do I, as a parent, advocate for my child today and make sure that they have a good, meaningful life today, and not necessarily pin that on all of the things that are outside of our control. I'm going to skip a couple of slides here just in the interest of time, but I think there's really important concepts or applications of this prognostic awareness concept that we could talk about, into the future, including at the time of diagnosis. We are offering families earlier and earlier genetic testing, and we know that prognostic awareness early in life, when someone is an infant or just starting to have symptoms, is lower. And so parents generally have much less prognostic awareness of what the future might hold for their child in early life. And the fact that we're able to offer them genetic testing early on is good for a lot of medical reasons. It helps drive treatments and strategies into the future, and understanding maybe of what the future might bring. But we're also asking families to carry the weight of the diagnosis or an impending decline or changes into the future for longer stretches of time. And for some people, this heightens their ability to focus on the present as well as to plan and prepare for the future. But for others, it steals from them. It steals from them time that would have otherwise felt more normal. And we just have to recognize that. Some states, are advocates for doing much more expanded testing early on in life around the newborn screen. And we just have to understand that that has some shadow side to it in terms of the way that families are psychologically moving through their experience as well. I'm going to just move to kind of our wrap-up slide here, back to the maroon bells scene. You can tell that the season has changed as we're back to maroon bells. It's no less beautiful than it was in the summer, and some would argue that there's more beauty to the fall season. There's an ominous contrast to the sky and the leaves here, and you can tell that it marks a transition and that there's some different hazards that are coming into view. And we know that when fall and winter are coming, there's ways that we prepare, especially for bad weather, logistically and psychologically. And for people who've not been through weather like that, we offer guidance about routes to avoid and ways to enjoy the season. And I believe that high quality communication, especially through pediatric neuropalliative care, through some of the things we've talked about today, can be like that, offering clear insight and guidance about things to come. And even when we want summer to stay with us forever, to be able to talk to families about what matters to them. So I'll wrap up here and leave you with this summary slide and my contact information, and we'll close with a Q&A. Thank you so much.
Dr. Treat, that was absolutely wonderful. Thank you so very much. Your passion and compassion for this topic certainly came through in your presentation. So again, thank you. I would like to remind the audience to enter their questions and comments in the Q&A tab within the attendee website. We have already received a number of questions, so we'll get to those right away. Let me scroll up here. So the first question says, thank you so much for clarifying the term goal concordant and best interest standard. What happens when a family's goals, best interests for their children are in direct conflict with the standard of care? For example, what if a family does not want gene therapy?
This is a great question, and I think it's one we're going to have to wrestle with more and more as we move into an era where gene therapy is going to become the standard of care. And to me, the next step is to understand why. What is it about that decision that is guiding them? And I tell my families all the time that I care more actually about the reasons why they're making the decision than what the decision actually ends up being. I mean, the treatment team needs to know, right? We need those actual decisions to happen. But what I care about a lot is how they got to their decision. Because if we can tell that they are making that decision through thoughtful and loving and caring reasons, and we can see that essentially meets the best interest standard from an ethical standpoint, then we as a treatment team can come around oftentimes to what they're trying to advocate for their child. And sometimes we can clarify misconceptions. Maybe they are afraid of something with the treatment that is less of a risk than they're perceiving. Sometimes we have different perceptions of risk about something. Sometimes a treatment team says, I don't really see that as a big risk, but the family is perceiving that as a really big risk. And so we need to even call that out. And maybe we won't agree on how big those risks are to one another, but at least calling it out and saying, we agree to disagree here, and we're going to go forward like this. That's how I think most of these situations get supported, whether it's through a palliative medicine team formally or just with the treatment team there, trying to understand why that decision is being made, and then understanding if that's a decision that has the child's best interest at the center of it. And I think a lot of times I use language like, what is it like for this child to live in their body? And are we trying to think about that as the center of our decision making? Oftentimes there's lots of relevant other pieces about the parent burden or the resources in the local community, some of these other things. And again, we have to call all of those out in order to understand if this really is the child's best interest.
I think you and I have recently had that shared experience with a mutual patient. So absolutely, great answer and great considerations. The next question says, with rare disease, patients often have a long list of providers and may be hesitant to add another clinic to the care team, and those patients can greatly benefit from palliative care. How can this be framed so as not to be conflated with PCP and others? Adding one more person to see and to visit.
Yes, so important and so appropriate to call that out for families. These families have really, really full calendars and they don't have any extra hours in their day. And so calling that out early, I think one of the things that I often hear is that this kind of visit feels like the visit where people are able to talk most frankly to them. And so hopefully that this kind of visit feels like a partnership in a really different way, but a really meaningful way. And even just one visit with a palliative medicine team, and then letting the family decide, is this worth something to keep on your agenda? I'm not trying to talk you into taking another team on for years and years into the future, but I want to offer this meaningful support to you. And I want you to try it maybe for 1 or 2 visits, and then you decide if it feels like a meaningful support for your family and for your child. I think that's a great way to go about it. And to just say that we're doing this in a proactive way, so that if and when there are decision-making points in the future, you don't have to go through all of those things during really high stress, that you can start to build some foundation. Some families also, really get bought in with that approach.
I would agree. I think families certainly appreciate the visits once they attend the clinic and recognize the value, but it is sometimes hard to add that one more layer for care.
We really recognize that there's a big hump to get over, whether it's the stigma, the mental, the worry, the fear, the logistics, all of those things. And so from my clinic, and partner clinics that you guys have in your different states, trying to understand how to help families get over that initial hump is a real thing. And it's appropriate to strategize around that, whether that's just saying, in that trusted relationship that you have with your family, about saying, I need you to just go once, and then you can decide, at least just getting that partnership and buy-in. But acknowledging it as a real struggle is appropriate and helpful in planning and getting someone plugged in.
Very so. Next question, what are the resources for healthcare providers that can assist in addressing caregiver exhaustion, specifically for palliative care?
Yes.
Great question.
Yes, it is. Yeah, I wish I had a magic wand to actually take it away or help it. I think that first of all, calling it out, again, helping someone feel seen and understood in that way, and understanding how it impacts on their day-to-day decision-making and big picture decision-making is really important. And families I think they see a lot of our work happen a little bit in an ivory tower sometimes, right? That their real life, they try to explain it to us, but we don't always understand the nitty-gritty of it. And so when we ask about things like waivers that they're supported by, or caregiving hours, or some of these other things, they're like, no one's ever asked me about that stuff before. And it makes a huge impact on their day-to-day quality of life, their ability to get sleep at night, their ability to run to the grocery store for something. And so I wish I had better tools to make it be less as far as like in the environment, and give them better home nursing and more resources where practical hands-on help existed. In the absence of that, we will continue to be advocates for more resources at the state level, and also trying to just engage them about where the gaps are, what they're seeing, and how then we might modify our medical treatments, if possible, to shift that burden or make it a little bit more palatable or a little bit more sustainable over time is also, an important part of the care.
Wonderful. Thank you. Well, unfortunately, we're out of time. Thank you once again, Dr. Treat, for a great presentation and also for your willingness to participate in MSRGN's 2023 Genetic Summit. It was greatly appreciated. Thank you.
For more information, visit mountainstatesgenetics.org/contact. This activity was brought to you by Mountain States Regional Genetics Network. Please enter this code in the evaluation survey in order to claim Genetic Counseling CEU. GS23-02.